So let's discuss the anatomy of external ear. Anatomy of external ear, we can as a train. We can think the ear as a train of three compartments. The outside compartment, the most external, is the external ear. The external ear. Then the middle compartment, also known as the middle ear, and the most inside compartment, that's known as the inner ear, So from the external environment to the internal environment, we can divide the ear into three parts. The external ear, the middle ear, and the inner ear. Clear? So we can see from this diagram, that this is the diagram of a ear. You can see this green color part. This green color part is known as external ear. Whereas this blue color part is the middle ear, and this orange color is known as the internal ear or inner ear, also known as labyrinth. So these are the three components of ears. The outside component, the one we are seeing, actually is the part of external ear. We call it pinna. We will discuss it later. The outside compartment is the pinna. The rest of the ear is inside the one bone. That bone is known as the temporal bone. So from the outside we can see some skin cartilaginous part of the ear, the whole ear. That is a very small portion. That is also comes under, this is a part of external ear only, but the rest of the ear is inside one bone. That bone is known as temporal bone. So the rest of the ear is inside one bone called temporal bone. So we will discuss the anatomy of temporal bone also, especially when we will discuss the mastoid, and it's more relation with the mastoid and the surgeries of the ear. We will discuss that one later, but let's discuss the external, whatever we can see from outside, the external ear part. So external ear having three components. So this is the green color is the external ear. This green color having the external ear. External ear having three components. Okay, the outside component is known as pinna. The one you can see from outside. This is our pinna. Okay, then we have one component called external auditory canal. Or meatus. After pinna, inside one canal is there. That canal is called as EAC or external auditory canal. The last part of the external ear, or the end of the external ear, is our lateral surface. The lateral surface of tympanic membrane. Tympanic membrane, that is our eardrum. So this tympanic membrane actually having three surfaces. Okay, the most external surface or the most lateral surface, if you think this is the midline, we are going towards the midline. So most external surface or most lateral surface of the tympanic membrane is under the cover of external ear. So this much is our external ear boundary. So we can see here we have pinna, then we have one canal. That canal ends into the tympanic membrane. That outer part or lateral part surface of the tympanic membrane is, all these three comes under the external ear. Clear? So this is about the external ear. Now we'll see the little bit about the first component, that is the pinna. So this is the first component or pinna. Fine. So before discussing the pinna, I think we can discuss a bit about the embryology of the external ear. If you see the embryology of the external ear, how it's developed actually. When during our development, if we draw in a diagram, if this is the brain vesicles, if these are the brain vesicles, this is our primitive heart. So this portion our primitive mouth or stomodium, this is our primitive mouth. So this is our primitive mouth part. Okay, this is primitive heart. Okay, so we can see from the heart, okay, and our brain vesicle, there is a gap is there, our neck part. That neck part is developed from our something called pharyngeal apparatus, pharyngeal apparatus. Okay, that is pharyngeal apparatus. In pharyngeal apparatus we'll see pharyngeal cleft, we'll see pharyngeal pouch. Okay, and arch. Okay, so one thing we have to know that pharyngeal, this word pharyngeal and branchial is same only. Some book it will mention pharyngeal, some place it will mention as branchial. So these two are same only. Let's see one photo of pharyngeal apparatus development. So you can see here the one picture which is taken from internet only, pharyngeal apparatus picture. Okay, so this pharyngeal apparatus, you can see this is the first pharyngeal arch. Okay, arch means the something. So actually in our development we have three primitive developmental tissue. What are the three primitives? Ectoderm, mesoderm and endoderm. You all know these three things. Everything developed from ectoderm, mesoderm and endoderm. Fine. Now you can see the outside part of pharyngeal apparatus is lined by ectoderm. This is the ectoderm. Fine. Inside part is lined by endoderm. Fine. And in between this pink color area is mesoderm. This much is clear. Outside is ectoderm, inside endoderm, in between mesoderm. Okay, now you see the outside part, this bulging is there. Okay, that outside bulging is known as arc, pharyngeal arc. Okay, that is a outside bulge. Okay, that is lined by ectoderm, right? And then there is one inside bulge also. Okay, and between these two bulges there is a depression. Okay, the depressed area is known as this. Between these two bulges there is a depression. This depression area, between the two outside bulges there is a depression, that is known as pharyngeal cleft. Okay, so pharyngeal cleft is the part of ectoderm. Okay, pharyngeal cleft is a part of ectoderm. Whereas you can see one depression is there inside also. Fine, one depression is there in inside area also. That depression, these depressions are known as pharyngeal pouch. That is a component of endoderm. So we know what is cleft, pharyngeal cleft, what is pharyngeal pouch, and what is pharyngeal arch. Okay, so arch, cleft, pouch. Actually the arch part, the mesodermal component also helps in formation of this arch part. Fine. This is a bit brief about the embryology. So from this arches pouches our ear, especially the external ear develops, okay, from these arches and pouches, and of course the clefts. So this is, we know all about the pharyngeal apparatus. Okay, now we come to the pinna. So pinna, from outside we can see the pinna. You can see the, what are the components of pinna? First, this area, this area is known as tragus. Okay, this red color area I am drawing, this outside area is known as tragus, this area. Okay, so this area is known as tragus. If you go little bit up from the tragus, you can see one arch is going upward. You can see one arch is going, or a rail track like structure is going upward. Okay, a cartilaginous structure is going upward. This structure is known as our helix. This structure is known as helix. Okay, and the root area is known as crux of helix. Fine. So helix, this structure is known as helix. Tragus clear, helix also clear. Now you can see this helix is going like this. Okay, keep on going like this. This is the helix part. Fine. And just opposite to helix, you can see the ulta, opposite is coming another bulge that is known as antihelix. That is known as antihelix. And antihelix having, when it coming upward, it divide into two crux. It divide into two lips. Okay, divide into two lips. The upper lip and the lower lip. Between these two area there is a triangular fossa. Okay, there is one triangular fossa. Okay, so by the time we know what is helix, what is tragus, what is antihelix, and what is triangular fossa. Now you can see between the helix and antihelix there is one depression that is known as scapha. That is known as scapha. Okay. Now we can see here, we can see our two major depression. Okay, two major depression. The one is upward, one is downward. The one which opens into the AC, that is the down part, the lower depression, that is known as cavum concha. It's known as cavum concha. Then upward one, that is upper one is known as simba concha. Simba concha. Fine. This much is clear. Okay, so let's revise the, of course the another part is there. When you are seeing the antihelix, at the bottom of the antihelix there is another bulge opposite to our tragus. That is another bulge. Okay, that bulge is known as antitragus. Fine, bulge is known as antitragus. Between the tragus, between the tragus and antitragus, there is one notch that is called intertragic notch. There is one notch called as intertragic notch. Fine. Now the last part, that is not a cartilaginous part, mainly the fat is there. This part is our ear lobule. Okay, so yellow. Okay, let's give one revision. First is our tragus. From the just upward part of the tragus is helix. This helix. Okay, then just opposite, just adjacent to helix, there is another structure going upward, another structure going upward, that divides into superior crux and inferior crux. That structure is known as antihelix. Antihelix in upward part divides the superior crux and inferior crux. That between these two crux there is a triangular fossa. Okay, and the lower part of antihelix ends by another bulge that is known as antitragus. Okay, and between the helix and antihelix there is the region of scapha. One more clinical important thing is between this tragus and your crux of helix there is one area which actually devoid of cartilage. Okay, it's actually devoid of cartilage. That area is known as incisura terminalis. That area is known as incisura terminalis. Okay, that area is known as incisura terminalis. Okay, so incisura terminalis. Okay, what is the clinical importance in the end oral approach? End oral approach for ear surgery. Okay, and for the end oral approach we use this area. Okay, we give incision. Incision is made in this area. Okay, that is the clinical importance of incisura terminalis. Right? This much is okay. Okay. Now little bit about the embryology of the pinna. Little bit about the embryology of the pinna we will see. Actually we have seen the arches, we have seen the arches and the cleft and of course the pouch. Okay, so arches, cleft and the pouch. Okay, now this pinna is developed from first and second arch. This pinna is developed from first and second arch. Fine. How is developed? This pinna develops from auditory tubercle, also known as hillox of His. This is an exam question for MCQ entrances. Okay, for this is a MCQ for entrances. Hillox of His. Pinna develops from hillox of His. So we can see the one tubercle like this. Na? Six tubercle, 3 from 1, 2, 3, 4, 5, 6. So 1, 2, 3 develops from first arch, they develop from first arch. 3, 4, 5, 6 develop from second arch. Okay. So what happened during the fusion of this tubercle fused together and form pinna. This tubercle fused together to form pinna. So while the fusion, this 2, 3, this 2, 3, 4, 5, 6. Okay, they fuse together first. So they fuse together first. Okay, later they fuse with the first tubercle. This other structure, other tubercle fuses first, later they fuses with the first tubercle. While fusion, if there is a defect in this area, first tubercle and the rest of the structure, it leads to formation of something called pre-auricular sinus. Something called pre-auricular sinus. Okay. So what is the clinical importance? That is, there might be recurrent infection. There might be recurrent infection. There might be recurrent infection of this pre-auricular sinus. In that case, we have to do excision of the pre-auricular sinus. Okay, fine. This is the clinical importance. Clear? Okay, clinical importance of the pre-auricular sinus. This much is clear. So this pre-auricular sinus will be somewhere. Show you, this is the tragus. Tragus is developed from the first tubercle. Okay, tragus is developed from the first tubercle. So this is the ear, in front of the ear. Okay, in front of the root of the helix, this area there will be one opening, that is the preauricular sinus of pinna. Okay, let's see some photo. So you can see there is a pinna developed from this auditory tuberculous or hillocks of his. Okay, the first one develops as tragus, second then the opposite silly you can see the sixth one developed as antitragus, third one is helix, and fourth one is antihelix. So somewhere this area, when there is a fusion failure, it may lead to preauricular sinus formation. Okay, that is the exam question. Fine, this much is clear. Okay, if this is clear, we'll go to the nerve supply of the pinna. We'll go to the nerve supply of the pinna. So you can remember this like this, that anterior part, this is the pinna. Okay, anterior part is supplied by auriculotemporal nerve. Anterior part is supplied by auriculotemporal nerve. Okay, so A for A, anterior part is supplied by auriculotemporal nerve. Greater part of pinna supplied by greater auricular nerve. Greater part is supplied by greater auricular nerve. So you can see here, okay, we can see here the anterior portion is supplied by auriculotemporal nerve. This one, the rest greater part is supplied by, even from the back side also, greater part is supplied by greater auricular nerve. Okay, so and the rest, the area which is the Simba concha area or concha cavum area, the area attached to the canal, from the canal actually two nerves come. This also posteriorly also you can see the attachment. From the canal two nerves come, the cranial nerve 7 and 10, facial nerve and the vagus nerve. These two supply the area adjacent to the canal. Okay, remember anterior part is supplied by auriculotemporal nerve, greater part is supplied by greater auricular nerve. From the canal two nerves comes and supplied the adjacent concha cavum area, that is cranial nerve 7 and 10. The posterior surface, the upper portion supplied by lesser occipital nerve also, that is not that important. Okay, auriculotemporal nerve and greater auricular nerve, these two area especially give for exam. Okay, this is about the anatomy of pinna. So anatomy of pinna, we can divide the ear in three parts: external ear, middle ear and internal ear or inner ear or labyrinth. The outside part we can see a bit part of external ear, the rest of the part is embedded in the temporal bone. Fine. Now the external ear having three components: the external pinna, then external auditory meatus or external auditory canal EAC, and the lateral surface of the tympanic membrane or eardrum. Fine. Coming to the pinna having few components like tragus, helix, okay, then antihelix. After antihelix we have the antihelix and in another bulb, that is antitragus. Between the tragus and antitragus there is intertragic notch. The area between the helix and tragus, there is a area which is devoid of cartilage, that is known as incisura terminalis. Clinical importance: in the endoral approach we give incision in this incisura terminalis area. A little bit about the embryology. Pinna develops from hillocks of his. If there is fusion failure, it may lead to preauricular sinus. Fine. Coming to the next component of external ear, that is EAC, external auditory canal. Okay, the length of the external auditory canal is 24 mm. Okay, that is an exam question. This 24 mm, the total length of EAC, and it's a S-shaped. You can say it's a S-shaped. Okay, and it's not, of course, that straight. It's not a straight canal. It's somewhat S-shaped canal. Okay, then it having two components. The outer part is the cartilaginous part, that outer 1/3 only, that is 8 mm, and the inner 2/3, that is 16 mm, is the bony component. Okay, so its component having both cartilage and bone. Okay, so outer 1/3 cartilaginous, inner 2/3 is bony. Fine. Narrowest part of EAC is the isthmus. The narrowest part is called isthmus. Of course, it's not at the junction. Okay, it's not at the junction. It's rather little bit. You can see this is the bony part. Okay, this is the bony part. So after there is one bulge. After this bulge, there is the area which is isthmus. Okay, that is the narrowest. There is a bulge. Okay, and this part is the narrowest part. Okay, that is the narrowest part. That is not at the junction of outer cartilaginous and inner cartilaginous. Not at the junction. Okay. Now we can see after this bulge there is a one depression. This depression is called as anterior recess. This depression is called as anterior recess. This depression is called as anterior recess. Okay. Clear? Now we can see the outer cartilaginous part. We can see the hairs. Okay, the skin is lined by the hair follicles. So otitis externa usually seen in this area. Otitis externa or furunculosis, because furunculosis is the infection of hair follicles. So you will see the hairs in the cartilaginous part. So furunculosis you will see in this area. Furunculosis you will see in this area. Fine. Now we can see the other component, like in the outer cartilaginous part there is actually a foramen. Okay, or a sinus. You can tell sinus is a blind, one end is blind. Okay, one end blind pouch, you can say. So in the cartilaginous part one sinus is there, that is known as sinus, that is, or a fissure is there, you can say fissure. Okay, in the outer cartilaginous part one fissure is there, you can fissure of Santorini. Okay, Santorini, fissure of Santorini. This outer part one fissure is there, it's called a fissure of Santorini. And in the bony part there one foramen is there, that known as foramen of Fusca. Foramen of Fusca. What is the importance? What is the importance of fissure of Santorini and fissure of Santorini? Fissure of Santorini. What is the clinical importance of fissure of Santorini and foramen of Fusca? Okay. With this two, infection from ear can reach surrounding area like parotid or skull base. Okay, and vice versa. Even from the parotid infection can come to the ear. Okay, so infection from ear can spread to parotid, skull base area through this thing. Another importance of foramen of Fusca, it is also responsible for formation of ear canal cholesteatoma. Okay, these are the importance of fissure of Santorini, which is present in a cartilaginous part, foramen of Fusca, which is present in the bony part. From these two foramen, infection from ear can spread to the surrounding structures like parotid, skull base area. Okay. Now coming to the nerve supply of the ear canal. If we can see this diagram of ear canal. Okay, the anterior part, of course, A for a anterior part is supplied by auriculotemporal nerve. This is a branch of cranial nerve, third division, that is mandibular division of the fifth cranial nerve, mandibular division of the trigeminal cranial nerve. Okay, so that is a branch of fifth cranial nerve, mandibular division. Auriculotemporal nerve will supply the anterior part. So this is the anterior part, this is the posterior part. Anterior part is supplied with the auriculotemporal nerve. Posterior part, the upper half is supplied by the facial nerve. You can remember 7, the cranial nerve 7 up. Okay, you can remember 7 up. The upper part is supplied by the facial nerve. The lower part is nerve supplied by the a branch of vagus nerve. The lower part is supplied by the a branch of vagus nerve that is known as Arnold nerve. Don't confuse this Arnold with this auriculotemporal. Okay, the Arnold nerve is a branch of vagus nerve. Is a branch of vagus nerve. Okay, that is 10th cranial nerve. That is 10th cranial nerve. Fine. This much is clear. Okay. Now, what is the importance, clinical importance of this area? Actually, if we do itching or like especially the syringing to remove the earwax, this vagus we can stimulate this vagus. If this vagus gets stimulated, there may be cough, there may be bradycardia, even vasovagal effect. Okay, even there may be syncope also. Okay, so you have to be careful in this area. And what is the importance of this upper part, upper posterior part, that is supplied by facial nerve? We can see hyposthesia in case of petrous apex tumor, which involves, in case of petrous apex tumor, we'll read it later, petrous apex tumor which involves the facial nerve, there may be hyposthesia in the posterior superior portion of the EAC. That hyposthesia is known as H for H. That hyposthesia of the posterior superior canal wall due to involvement of the facial nerve with the petrous apex is known as Heiselberger sign. Is known as Heiselberger sign. Is known as Heiselberger sign. Clear? Clinical importance. Okay. Another clinical importance is this facial nerve sometimes get effect in the herpes zoster also, that is known as herpes zoster oticus or Ramsay-Hunt syndrome or Ramsay-Hunt syndrome. Okay, so one is Heiselberger sign, another is Ramsay-Hunt syndrome. These are the nerve supply. Now coming to the tympanic membrane. Tympanic membrane area is very important and very vast also. We'll try to see one by one what is there. So if we draw a diagram of tympanic membrane, if we draw a diagram of tympanic membrane, in any way we can draw one diagram of tympanic membrane. Okay, from the outside what we can see, from if I am seeing from this side with my otoscope, what we can see there is a tympanic membrane, color is pearly white, as book says, color is pearly white. Okay, so you can see that this is the normal tympanic membrane, this is the pearly white, this is the area of tympanic membrane, so what we have drawn. Okay, this is the area of tympanic membrane. Fine, so let's draw it again. This is the area of tympanic membrane. Okay, this area is, this whole area is known as, this whole area is known as, so to draw it again and again so that you will remember it. Okay, this area is known as pars tensa. Okay, this area is known as pars tensa. Fine, this point is known as umbu. This is handle of Malleus. This area is known as pars flaccida. Okay, so you can see here also umbu, handle of Malleus, pars tensa, and this upper portion is the pars flaccida. Okay, you can see one cone of light here. You can see one cone of light here. When use otoscope, the otoscope light reflects here. Okay, this cone of light area, this is cone of light. In disease of medulla, this cone of light get distorted. Okay, and cone of light will be always in the cone of light, that is a question. The cone of light will be always in the anterior inferior quadrant. So if we divide the pars tensa in 4 quadrant, if we divide the pars tensa in 4 quadrant, the cone of light will be always in the, this is anterior, this is posterior, inferior, superior. So cone of light will be always in the anterior inferior quadrant. Fine, that is exam question. Clear? Okay. So as already discussed, tympanic membrane having two components, pars tensa and pars flaccida. Pars flaccida also known as Sharpnell's membrane. Pars flaccida also known as Sharpnell's membrane. Okay. Pars tensa, why it's called pars tensa? Actually, according to some books, the pars tensa having 3 layers. Okay, outer layer, that is part of external layer, the epithelial layer or lateral wall, then middle fibrous layer, then inner endothelial layer. Outer epithelial layer, middle fibrous layer, and inner endothelial layer. In case of pars flaccida, only 2 are present, the outer epithelial and inner endothelial. Mid fibrous area is not there, that's why it's flaccid. Okay, no, not that tense. Okay, pars tensa is very tense because of 3 layers, but according to some books, this fibrous layers present in both cases, but the pars tensa fibrous layers is well organized. Okay, well oriented, the fibers are well organized, but in pars flaccida the fibers are not organized and very minimal also. That's why this flaccidity of the pars flaccida or Sharpnell's membrane. Fine. The pars tensa is at the outer border of the pars tensa. If you can see this area, the pars tensa, the outer border, if you can see this part is a thickened part. Okay, this part is a thickened, this area is a thickened part, that is known as tympanic, that is known as, this thickened part is known as tympanic annulus. This is known as annulus. This is known as annulus. This annulus actually get attached in a bony sulcus, a bony groove, that is known as. So if it is the annulus, it's attached in a bony groove. If it is the annulus, it is attached in a bony groove, that is known, groove is known as tympanic sulcus. That groove is known as tympanic sulcus. Fine. And this pars flaccida is attached this in a bony notch called notch of Rivinus, notch of Rivinus. Okay, notch of Rivinus. This is clear. Now little bit about the dimension of tympanic membrane. The diameter is also 9 to 10 mm, and the square area also 9 mm square surface area. And this tympanic membrane is not perpendicular. Okay, it's not perpendicular, rather it's in a 55-degree angle, rather it's in a 55-degree angle with the horizontal, 55-degree angle with the horizontal. Fine. Now the blood this one, nerve supply of the tympanic membrane, nerve supply of the tympanic membrane. The inner surface is always, so if you can see, this is the EAC, this is the external canal, EAC, tympanic membrane, and here you middle layer. The inner portion is supplied by the ninth cranial nerve, that is glossopharyngeal nerve, through a branch called Jacobson nerve. Previously we have seen the branch of 10th cranial nerve, which is known as Arnold. Now it is a branch of 9th cranial nerve, that is Jacobson nerve. We can remember that J looks like 9. Okay, J looks like 9. So Jacobson nerve, the branch of 9th cranial nerve, that supplies the internal part, the medial part of the tympanic membrane. Okay, at the outside part again supplied by the auriculotemporal nerve and vagus nerve through Arnold nerve branch. Okay, so this is all about the tympanic membrane anatomy. So we have seen what are the things we have seen. The ear is divided 3 parts: external layer, middle layer, internal layer or inner ear. The external layer having 3 components: the pinna, the EAC and the tympanic membrane. EAC, pinna we have already discussed, the embryology, anatomy, and clinical importance. Then EEC also the outer cartilaginous, outer 1/3 is cartilaginous, inner 2/3 is bony. Outer cartilaginous line with the hairs, furunculosis or otitis externa develops. The furunculosis develops this area. The bony part we have the narrowest part of EAC, that is the isthmus part. Okay, so outer is 8 mm in the length and the inner is 16 mm, total 24 mm. Right? Now the EEC having two fissure or opening, in the outer cartilaginous part, that is fissure of Santorini, and the inner bony part, that is foramina fusca. These two opening actually helps in transmission of the infection from the ear to the surrounding tissue area like parotid, like skull base. Okay. Now the foramina fusca also can with the area of ear canal cholesteatoma. Okay. Now the nerve supply we have seen, the anterior part is supplied by the A4A auriculotemporal nerve, the posterior up 7 up supplied by the 7th cranial nerve, facial nerve, and the lower part is supplied by the your vagus nerve through a branch that is known as Arnold nerve. Fine, that is known as Arnold nerve. Now if there is a if we scratch in that area, the posterior inferior area, or during syringing, the vagus can get stimulated, that may lead to cough, bradycardia, even syncope. Whereas the facial nerve can be affected in case of vitreous apex tumor that leads to hyposthesia of the posterior superior canal wall, that is known as H4A hyposthesia in Heiselberger sign. Right? Another thing, the Ramsay-Hunt syndrome or herpes zoster oticus can involve in this region also. Okay, there will be blister in this portion of the EAC and there will be severe pain. Okay, we'll see the clinical symptoms, the clinical conditions in separate chapters also. Regarding the TM, we know we have core two component, pars tensa, pars facida, having three layers: outer epithelial, middle fibrous, and inner endothelial layer. The pars tensa, this one boundary of the pars tensa is thickened, is formed tympanic annulus, that is embedded in a sulcus, bony sulcus called tympanic sulcus, and the pars facida is embedded in the bony notch, the notch of Rivinus. Right? Regarding the dimension, the diameter is 9 to 10 mm, the surface area is the 9 mm square, and it's in a 55-degree angle with the horizontal nerve supply. The inner portion is supplied by the branch of 9th cranial nerve, glossopharyngeal nerve. That branch is known as Jacobson nerve, and the outside part is again supplied by auriculotemporal nerve and vagus nerve. So this is the introduction about the anatomy and little bit embryology with the clinical part of external ear. So we'll discuss the other portion of the ear in subsequent classes.